Hey there, my name is Ismail. I'm a fifth year med student at Najah National University Hospital in Palestine. And today I want to explain to you tachyarrhythmias. And, I like to start with a UWord question, just like that. If you don't know what UWord is, it's basically a question based a learning system. It gives you a question and there is an explanation at the end where they explain to you what's the right answer and why they pick it, and also excluding other answers as well. So we're going to start with the questions, and obviously I would like you to pause a bit and actually try to solve it by yourself. And it's fine if you get it wrong. We're gonna obviously get through it and why we actually chose the answers, and also explain to you in details what tachyarrhythmia is and how to approach them. So let's get started. So we have a 68-year-old man, already a very old age, comes with palpitations and mild dizziness and sweating. So obviously interesting shift complaint, which is palpitations. Symptoms started 30 minutes ago, and he has no chest pain or shortness of breath. This is very important. When someone tells you like there's no chest pain, you should always exclude a lot of inflammatory conditions, because as you know, if there is no chest pain, there is no inflammation, and inflammation conditions like, for example, pericarditis, myocarditis, you probably need to exclude them. Maybe MI as well. All of that actually, it should come with chest pain, because inflammation is there in these type of conditions. So it will save you a lot of time if there's no chest pain. There's no shortness of breath. Obviously, there's no involvements of the lungs. For example, like a backflow of fluids from left ventricular failure, for example, or respiratory pathology in general. Okay, so medical history is significant for hypertension and myocardial infarction 6 months ago. Let's just pause a bit here. When in the questions tells you that he has a history of myocardial infarction, you should always think of the complications of MI. Now, complication of MI, obviously, we're gonna explain it briefly. I like to remember them from right side of the patient and this left side of the patients. Start with the right ventricle. Obviously, if there is the right coronary artery is affected, which supplies the SA node, there is SA node dysfunction, which may lead to right ventricular heart failure. So this is the first complication that might occur. The second complication that might occur and just moves from the right to the left, you hit the septum here. Actually, one of them is intraventricular septal rupture, which may just, there's kind of left to right shunt, because obviously this is high pressure here. The flow gonna go from the left to the right side and causing a biventricular failure. And this is the second complications. The third complication is papillary muscle rupture, which may cause mitral valve abnormalities. The fourth complication is basically a free ventricular rupture. And the fifth complication is ventricular aneurysm. Now, why do I say that? Because the first complications, as I mentioned, right ventricular heart failure, interventricular rupture, papillary muscle, this actually happens 3 to 5 days post MI, whereas the free ventricular rupture will happen 5 days to 2 weeks. Now, this patient had MI 6 months ago, which is relieving that it's not one of those. But the only two complications that may occur after MI from that long is either ventricular arrhythmias. They may occur literally at any time. If it's instantly after the MI, maybe after 1 month, after years. Secondly is ventricular aneurysm. Basically, just the heart has an aneurysm here that may cause clotting. They may occur stasis in the blood there, actually causing left ventricular heart failure as well. So you should just keep it in mind. And I mentioned that because this, the case is actually about ventricular arrhythmias, and from the history, as long as he mentions myocardial infarction 6 months ago, that's probably the most important risk factor in this case. Okay, we move on. Smoking. Obviously, blood pressure is very important to know that this patient is not severely hypotensive. Now, if the patient actually has below 90/60, you should know that, okay, this patient may have different management. This patient does not have severely, hypotensive. If he was, for example, below 60, here it's probably a different measurement. We're gonna mention that in the future a bit, okay? And this patient also has a very high pulse, more than 150. Also pay attention to this number specifically. Oxygen is okay, and physical examinations, I don't care about all of that. He's talking about jugular vein pulsation is visible, so obviously meaning there's a right ventricular failure. which may occur per se, that this patient actually have cor pulmonale, or maybe he has left ventricular failure causing backflow to the lung and backflow to the right ventricle causing right ventricular heart failure as well. ECG is what matters here, definitely. He's showing or telling us it's regular white complex tachycardia. And obviously, this is the landmark of the question. Actually, these questions, you're probably gonna, forget all of it, but the ECG tells you regular white complex tachycardia, and you would instantly know that this patient has something called VTAC. So, obviously, the answer is gonna be C. Let's exclude other conditions, or like, why, for example, A is not the right answer. Now, aortic regurgitations, you might see it in different conditions. I'm gonna mention a few. One of them is definitely Marfan syndrome. Now, Marfan syndrome, basically, the patient's gonna come to you, very long, probably like over 180 or 190 centimeters, having, for example, leg to torso ratio is very big, have Marfan habitus, very thin patient, and suddenly he has like a severe chest pain, aortic dissections, and regurgitations. Okay, this is probably one of them. Secondly, is probably infective endocarditis, basically a rheumatic fever that may actually occur and causing vegetations on the aortic valve, causing aortic regurgitations. That's actually one of the answers as well. Now, obviously, this is not the case here because you would assume there should be a murmur in the question, maybe chest pain from aortic dissection, so it's not definitely the answer here. Aortic, obviously, atrial fibrillation. The landmark is going to be in the ECG, saying irregular rhythm, not regular. So we're gonna mention it again, but obviously gonna exclude it here because it's irregular. If it's irregular, then probably could be atrial fibrillation. Yes, if it's obviously no. Um, this is right answers. Pericardial effusions, obviously you see it also in a lot of conditions. I'm gonna mention a few. Two most important ones is probably a patient that comes after a viral infection. So let's say just a patient like in his 40s, 30s, whatever the age is. He had like rhinorrhea or coryza or like just infection in general, upper respiratory tract infections, and after 2 weeks he developed chest pain. It's 100%. I'm not gonna say 100%, but it's definitely something related to the pericardium or the cardiac itself. For example, viral myocarditis or pericarditis. So obviously this is a prodrome syndrome. The other one is probably after a surgery. For example, if you open the patient up, may actually have pericardial effusion. It's probably not. Obviously, there's no chest pain here, so it's probably not the case. Or post-MI actually happens, but happens as we said 5 to 2 weeks, so it's probably not as well. Tricast regurgitation also happens in different conditions. It's either complications of right ventricular heart failure because when the right ventricle is very big from the fluid, the tricast valve gonna stretch and will cause tricast regurgitations. The other one is probably, and it's very very high yield. A lot of questions happen that someone with IV drug abuse. There's a staph aureus on the skin when you insert a needle. The staph aureus is gonna join and will go to the inferior vena cava and the central venous return, and the first valve they're gonna be hit is the tricusp, and obviously will cause tricusp regurgitations. So the answer is C. Okay, let's start with tachyarrhythmias in general. And tachyarrhythmia is obviously, when I say to the patient that you have tachycardia, most guidelines actually prefers 90, not 100. Okay, it's recent, but obviously most resources still believe it's more than 100. Tachyarrhythmias, it's more than 150, and it's probably because they want you to assume AV and RT in your differentials, because AV and RT is diagnostic at this type of tachyarrhythmias. So if it's more than 150, it's probably not sinus tachyarrhythmia. It's not like from stress or like he was anxious or was anxiety. No, it's probably one of the supraventricular tachycardias. Mostly they're gonna reach this type of number. Okay, let's go with ALS managements, and I'm gonna explain what obviously the tachyarrhythmia is, then the management. But you should know that the first thing when the patient comes, you start with ABC, blah blah blah, whatever, like airway, breathing, circulation. Also here very matters because you're dealing with an organ such as the heart, so you need to obviously assess if it's stable or not before anything else. The stability here, actually, I don't care about this one. It's the three main things I want you to remember. It's called brain, resp, heart. The brain is the patient's altered mental status. Is he with us? Is he conscious? Is he oriented? Respiratory, is he having respiratory distress? Because there's fluid in his heart, for example. Heart is basically hypotensive. Is he not pumping blood enough? Is he hypotensive? Obviously, what I meant by hypotensive is below 90/60, because if it's not this number, either one of them, obviously, there's nothing, for example, the brain or the wrist, this patient management is definitely not a cardioversion, not going to shock him. We're gonna only do medical treatments because he's not hypertensive yet. So keep that in mind. I'm gonna explain it also in a bit. Okay, so we're gonna go with tachyarrhythmias. Now tachyarrhythmias, there's a lot of, you can see. There is ventricular VFib, dorsal point, VTAG, Wolf Parkinson's, atrial fibrillations, flutter, and SVT. Now, these all differentiated by ECG. This is important. Clinically is kind of hard to distinguish between them, because most of them obviously comes with tachyarrhythmias, palpitations, sweating, diaphoresis, but you need to assume ECG first, and you're gonna ask two questions. Is the QRS broad or narrow? And it's regular or irregular rhythm. I'm gonna give you some hints to actually never forget them. Now, if there's a word ventricles or ventricular, for example, here, VTAC, it has the word ventricles, right? SVT, supraventricular, so it has the word V, right? Ventricular fibrillation is different, because I'm gonna tell you why it's different at the end, but just any word has ventricle, there is a rule for it. What's the rule? Just remember, just like, I'm gonna explain the pathophysiology. Obviously, it's basically when the SA node is cooked. I would say it's just not working anymore. The ventricles will take over, meaning the ventricular myocyte or the AV node, which is below the SA node level or the atrial level, gonna take over. So when they're gonna take over, there's no B waves, because the B waves is produced by the SA node. So these patients will not have B wave, but at the same time it's going to be irregular, because the automaticity of the heart comes from the SA node to AV node. AV node comes from the Purkinje and moves in from the nose and everything. But at the same time, all of these myocytes and the neural cells have its own automaticity, so it's going to be regular at the end of the day, even if the SA node is dysfunctional. So these patients with any ventricular rhythm, you're going to assume two things. It's either B wave is not going to be there, and the second is going to be regular. So that's the role of anything that has ventricle in it, except VFib, because this you need to memorize the look of the VFib. Okay, so let's move on. I draw a bit of diagram for you. You can assume this one if you want. So we're gonna start with tachyarrhythmias. As we said, it's more than 90 if it's tachycardia. Tachyarrhythmias most is gonna be more than 150. As we said, if it's hemodynamically stable, we mentioned three things: brain, altered mental status, respiratory depression, or hypotensive. If it's no, he's not hemodynamically stable, instantly cardioversion. Basically shock the patients, because you have no time, there's no perfusion, this patient is already in hypoxic situations for the brain. You need to shock him no matter what the consequences are. Okay, if yes, he's hemodynamically stable, okay, you have time to do ECG and type of look what type of tachyarrhythmias he has. So you start with ECG. As we said, we ask two questions: if it's wide or narrow QRS, or regular or irregular. Okay, so let's say it's a wide QRS, meaning it's more than 12 seconds, but it's gonna be like 3 small boxes if you want to remember it this way, or just more 0.12 seconds. Now, if it's wide, you're gonna ask the second question, as we mentioned, is regular or irregular. If it's regular, it's VTAC, and as I said before, V or ventricle, any ventricles, meaning there is no B wave, okay, and it's regular, right? So that's, as we said, regular, and it's VTAG, and it's wide, okay? So this is VTAG. Now, what to do with VTAG patients? If he is hemodynamically stable, you go with amiodarone. If he's not stable, you do cardioversion. Just as we mentioned here, if it's hemodynamically unstable, you do cardioversion. But if he's stable, you do amiodarone, and you need to memorize this. Amiodarone for VTAG. Whatever it takes, you need to memorize it. Now, if it's irregular, it's probably something called Tourasti point, and you need also to memorize magnesium for this type of disorder. And cardioversion, if he's unstable, I would say here. Okay, what if it's actually a narrow, below 3 boxes, smaller 3 boxes, and below point 12? You ask the same question, is it regular or irregular? So if it's actually regular, as we mentioned, anything that have ventricular in it, you say there's no B wave, and it's regular. So here it is, it's regular, but the difference is it's actually a narrow. Okay, so you have this parallel here, V tag SVT, basically all the same thing. It's regular, but it's just narrow here and it's wide here. Okay, ABNRT is literally an SVT. It's literally very similar. So I put it in the same way. Now, what's the treatment of it? If the patient is stable, you give something called adenosine. And if it's unstable, as we mentioned there, it's going to be cardioversion. The difference is here's synchronized and here's unsynchronized. I'm going to explain it why in a bit. Irregular here is going to be afibrillation. Now, afibrillations, you obviously know it's an irregular rhythm. That's what they call it. And it's actually irregular here, but it's narrow. Make sure it's narrow. Obviously, if it's stable, there's a guideline called rate rhythm control. If it's unstable, as we mentioned, you just do cardioversion. Now, if it's stable, rate or rhythm control. I'm going to explain, obviously, the drugs in details in a bit. Okay, here's how to calculate the tachycardia. Obviously, you know, the rule of R to R, like over 5 and those things. You just read them by yourself. It's very easy. Now we'll just start with some ECGs as we mentioned. Now we mentioned about something called SVT. We said it has the word ventricles. So what did we learn? Ventricles took over. So there's no B wave because it's not coming from the atria or the SA node. And we said it's regular, right? And we said also it's a narrow complex. So 3 here, you can see there's actually no B wave. This is actually a T wave. Now, if you're confused between these two, if it's a T wave or a B wave, just assume it's a T wave because there's literally no way on earth that you're gonna see an ECG that does not have a T wave, unless obviously hypokalemia and these electrolyte imbalances. But in general populations where you suspect tachyarrhythmias and you only see one dome per each beat, you can assume it's a T wave. Because B wave, it's fine to be absent, but T wave in this situation is probably never absent. So it's actually a T wave. So there's no B wave here. As you can see, it's regular rhythm. That's the other one. And it's a narrow, right? Narrow, it's below 3 small squares. Now, the triad here is definitely an SVT, okay? Okay, you go with atrial fibrillations, and this is something that you need to memorize. It's called sawtooth appearance. Sawtooth appearance, basically, as you see, there is actually 3 B waves back to back here, like a saw. Saw is basically, I don't know if you guys know Arabic, but it's like minshar. That's a saw. So you need to memorize like 3 Bs, maybe. You need to memorize it in a way. It's atrial flutter. And the management for this type of patient is similar to atrial fibrillation. So you start with rate or rhythm control, which I'm going to explain in a bit. Now, a fast atrial fibrillation, or just assume it's a atrial fibrillation, as we said, it's a narrow, and we said it's irregular rhythm, meaning it's irregular, and obviously there's no B wave. There's no B wave, and it's irregular and narrow. You can see here, this is a T wave. There's no B wave, no actual B wave. If there is one, it's not enough. It has to be like 3 B waves in a row that you might consider it, oh, there is actually a B wave. But obviously it's irregular. You can see this is longer than this, for example, short, long. So it's irregular, no B wave, and irregular rhythm. This is atrial fibrillation, typical atrial fibrillation. Okay, this is VTAC. VTAC is, as we said, it's gonna have the word ventricles, and the word ventricle will tell you ventricles took over. So there's no B wave, there's nothing come from the atria because ventricles took over in a synchronized way. So it's regular. It is regular. There's no B wave. It's regular, and obviously it's wide. Okay, it's very wide. So it's regular, wide, no B wave. And actually, if you can see clearly, there's no T wave actually, and T waves is probably because the white QRS complex will not make you see the T waves because it's very low voltage, and it's in a repolarization stage, so you're not going to see it because the QRS is wide basically, but it's probably present. Now V fibrillation, it's something that you should memorize by your eyes only. If you see something like that, just like gribbish basically, you just garbage drawing like that, it's definitely a VFib, and you instantly go for cardioversion because this is life threatening. Basically the ventricle is trying to move, but it's restricted by depositions or by arrhythmias, and you know different pathophysiologies for it. Obviously most commonly is MI, because after MI you have fibrosis of the myocytes, and there's fibrosis of the myocytes, you're going to lose the function of it, and it cannot contract anymore. And when there's no contractions, or there's an ability to contract, which is basically like the myocyte is trying to contract but it's not fully contracting, making this type of very small QRS complexes. But this is obviously V fibrillation, which will kill the patient, so you should instantly do cardioversions or basically shock the patients. Torsades de Pointes is another thing that you should memorize by your eyes. See the comparison between these two. Actually, it's very, very hard to kind of comparison because both of them just look alike. And, hopefully you're lucky in your exam. These type of things gonna come because it's easy to memorize and, look at it. But Torsades de Pointes is basically a VTAG, but it's polymorphism. So it has a lot of VTAG but different shapes. And, you should memorize that by your eyes. And instantly first line treatment for it, if it's stable patient, you do IV magnesium. And this comes in exams very, very much. So you should type of write it in your notes or something, IV magnesium for Torsades de Pointes. Now, Wolff-Parkinson-White syndrome is basically, call it even AVRT. We mentioned AV and RT, right? But this one without the N, which is the nodal part. Wolff-Parkinson actually has a very specific pathophysiology. It's basically when the heart has connection between the atria and the ventricles. There is a pathway here that the electricity that comes from the SA node will go like that, and normally it will accumulate in the AV node and continue its way. But obviously when there is a pathway here, it's gonna kinda not go from the AV node, and it will go instantly to the ventricles. So there is shorter time from the electricity goes from the atria to the ventricle. That's why there is tachyarrhythmia, is because there's no AV node delay, if you remember the physiology, normal physiology. So obviously there is going to be tachycardia. But there's kind of specific finding on ECG that always comes in your exam, by the way. I'm going to just draw it here. Let's just assume this is a P wave. There's a slurry, move like that. Then distorted T wave like that. So it's something like that, I'm sorry. This is called delta waves, very specific for Wolff-Parkinson disease. There's three findings here. First, the BR interval is short. Secondly, you can see this is something called slurry, QRS, or slurry, for example, Q wave, or R. And three is distortion in T, or we call it obviously the ST segment. There is distortion here. It has a lot of shapes, but this type of triad you'll see in something called a delta wave, and this patient definitely has Wolff-Parkinson. And what's the drug used for Wolff-Parkinson? Comes in the exam a lot. It's not written here. It's called broconamide. This is obviously antiarrhythmic drug, class 3, if I remember correctly, used in Wolff-Parkinson disease. And, one of the side effects, the very important side effects, is SLE-like syndrome. Okay. Um, yeah, you just explain some pathophysiologies really fast here. As we said, VFib is just fibrillation in the myocyte. VTAC is basically when someone has, for example, MI, lose its function, and the cell will die. Very similar to VFib, but it's definitely the stage before reaching the fibrillation. It's actually a VTAC. Atrial fibrillation, obviously, there is a very unique pathophysiology of it. So there's the heart, and there is pulmonary veins. There's 4 pulmonary veins. Now, there is type of very kind of weird mechanisms about, let's say this is a mitral valve, and let's assume this patient has something called rheumatic fever. Now, rheumatic fever is basically when a bacteria called streptobiogen goes to your mitral valve and making depositions there and vegetations. It will cause, at the end of the day, something called mitral stenosis. And when there's mitral stenosis building here, you're assuming that the left atrial here gonna obviously accumulate more fluid because if there's a stenosis, it's like a bottle and you just type of stenosis up there. So the fluid gonna accumulate and there's gonna be stretching on the wall of the atria. And when there's stretching on the wall of the atria, there's gonna be fibrosis to accumulate and eccentric and concentric hypertrophy, but in the atria does not have this ability, so it will just stretch, and when you stretch, you're gonna stretch also the neurons, and you're gonna also make type of weird elasticities and weird neurological damage to your neurons, and it will build a lot of stretching on here, and with the stretching on here, obviously you're gonna have some distorted neurological signals. Obviously, the mechanism is not as clear, but it's hypothesized that it's probably that's what's causing it, because they show like a lot of research showed that mitral stenosis is very probably one of the most important risk factors for this condition. Atrial flutter is kind of similar to atrial fibrillation, but it's actually the signal is going to be around the tricusp valve this time. So the AFib is around the pulmonary veins, but the atrial flutter is around the tricusp. Obviously, I didn't explain them in detail because it's still unclear mechanisms. Okay, I'm sorry, I forgot to explain the drugs in detail, kind of. But amiodarone is basically, let's just start from here, VTAC. Amiodarone is basically class 3 antiarrhythmic drug. And class 3 basically works on the QRS complex in a very weird way, if we can explain it in the step 1 version. But it works as an antiarrhythmic drug that may actually save you from, tachyarrhythmias, especially on the QRS level. Towards the point, we're using magnesium to stabilize the patients before cardioversion. It's not really, it's just an electrolyte that, happens to actually help with the totality bonus because it decreases the QT interval. That's what the mechanism is. SVT is adenosine. Adenosine actually works on A1 receptors. It's a very unique receptor, and A1 is found on the AV node. And what happens is if it goes and activate the an A1 receptor, the AV node will decrease the flaring, basically decreasing the increase the parasympathetic innervations on the AV node, causing the heart to relax and decrease the contractility and decrease also the the heart rate. AFib, there is rate and rhythm control, and what I mean by it, and rate control is basically you just decrease the heart rate, right? There's a lot of drugs that causing it. There's actually 4 famous drugs: beta blocker, digoxin, CCB, and what's also beta blocker, obviously digoxin, CCB, and the rhythm control. The rhythm control is basically the class 3 antiarrhythmic drug, most commonly used. Beta blocker, obviously, you're not going to use it in someone, for example, having atrial fibrillation but also having heart failure, because you don't wanna like affect the contractility in this patient because he is having heart failure, and if you do beta blocker, he's not gonna pump blood anymore, and there's gonna be congestions even more. Also, digitalis kind of contraindications in heart failure, but CCP, for example, is nice done in these type of patients. So everything is basically based on the history of the patient, but this is the three drugs that's using as a rate control. And you always start with rate control, not rhythm control, because rhythm control is basically this patient having atrial fibrillation, right? And there's like as we said, mitral stenosis most of the cases. So there's gonna be like a thrombi, and if you somehow change the rhythm into a normal rhythm or a sinus rhythm, this thrombi might actually go into the brain and causing cerebral hypoperfusion and death. So before you do that, you do like ultrasound or something called echo in your heart, and you can see if there's a thrombus or not. But obviously, you just don't do that, and just start with a beta blocker, for example, or a rate rhythm control first. This is probably a better option. And yeah, I think that's it for tachyarrhythmias. It's very short review, but yeah, hopefully, it was nicely done.